Thank you, Dr. Fendler, for that great presentation. The next talk is actually all the way from the US. We've had a US international in person, Professor Thomas Hope from UCSF, who's a nuclear medicine lead and chair of that program. And the talk is entitled Spoilt for Choice, Gallium-68 PSMA, F18 DCFYPL, and F18 PSMA 1007. Is there a difference? And after this talk, you can ignore my question on the Q&A because it's probably be answered.
Now you make me wonder what the question is in Q&A, huh? Well, it's lovely to go after Dr. Fendler. It's been an interesting number of years here and great to be with people who I've met in Zoom world and obviously before then and see where this field's come with all these people we've collaborated with over the years. So it's been a really wonderful path, and I'm just obviously very happy to be able to make it here in person. And Michael, for you for inviting me and hosting me, and it's been really wonderful. So I was asked to give a talk called Spoilt for Choice. In essence, do any of these different PSMA radiopharmaceuticals make a difference? And to a certain extent, the answer is, I find the question of is there a difference not that interesting compared to the last talk, what was just presented by Wolf. Those are the questions that really make a big difference clinically, and hopefully by the end of this we'll highlight a few differences, but this is really not where we should be spending our time anymore, is worrying about how does A versus B differ. They're minimal, and hopefully we'll end this talk by agreeing upon that and move on to actually the clinically important questions, which we'll actually do research on moving forward. So I'm not sure if I'm required to put disclosures, but I'm so used to putting disclosures in. That's San Francisco, another beautiful town in the world. So just to remind ourselves, there's a lot of these agents, and they all actually look very similar. So if you remember, this urea motif is sort of the backbone of all PSMA PET radiopharmaceuticals, and they have different chelators. So PSMA 617 has a DOTA chelator. For the few radiologists in the house, that's the same that's used for Dotarum. I don't actually know if they call that the same drug. It's a gadolinium-based MR contrast agent, the exact same molecule. And then you have DCF-PYL, which is fluorinated, HBED-CC, PSMA 11, a different chelator that works great with gallium up in the top left. PSMA 1007 is also fluorinated and has a motif that will bind a little bit of albumin that's lipophilic, so it gets cleared by the kidneys, as you'll see. And then RHPSMA 17, which is a little odd because it has both a DOTA chelator and is fluorinated. So the idea there is that you might be able to, I don't know why you'd actually want to do that, but image it with fluorine and actually treat some with lutetium simultaneously, whatever the use is for that. Now, these are actually all in or completed phase 3 trials in the United States. So DCF-PYL, PSMA 11, and PSMA 617, bottom rows, all FDA approved. 1007's in phase 3 trials, RHPSMA 7's in phase 3 trials. So there's going to be not just spoil for choice with DCF-PYL versus PSMA 11 in the United States, but a whole nother set of these compounds is coming down the road. And to me, when I think about the difference between these, it's about biodistribution, right? They have the same binding moiety, and so it's the chelator that's going to change their biodistribution slightly. So you can see PSMA 11 on the left and DCF-PYL. Those actually have very similar biodistributions, right? They're both predominantly renally excreted. PSMA 1007, you can see the liver, very hot, right? So it's got hepatobiliary clearance. The idea here is, and they chose this image obviously because you can see local recurrence potentially better because there's no radioactivity getting cleared through the bladder. On the far right, you have RHPSMA 7, which I have no experience with, so I have to rely on the literature and Matthias Eiber in terms of what to think about it. But in this setting, there's a little more hepatobiliary clearance. It's not as much as you see with PSMA 1007, but you can see there's much less activity in the renal collecting system. And so as we gain more experience, it'll be interesting to see if it ends up being sort of an in-between between 1007 and PSMA 11. But in general, in terms of their ability to detect disease, they seem to be all very similar. The predictive value, the sensitivities, stratified by PSA are very similar, and it's just the biodistribution that ends up being different. Now, this is one of my least favorite articles in nuclear medicine. This was published now 7 years ago and compared DCF-PYL to PSMA 11 and claimed that DCF-PYL was better than PSMA 11. And I love the figure. This is from their manuscript. This is the one patient figure they showed that was proving why DCF-PYL was better than PSMA 11. And you can see on the left there, that's a DCF-PYL image, and it does show actually more lesions than the PSMA 11 image, right? And it just sees one lesion on PSMA 11. Now, I put the technique there in the boxes. So for DCF-PYL, they administered 360 megabecquerels. I put millicuries in there just so I have some idea of what we're talking about. And they did a 120-minute uptake time. right? For PSMA-11, they gave 1.7 millicuries, or 64 megabecquerels. And hopefully no one in this room will ever use that low of a dose when doing a PSMA-11 PET, and did a 60-minute uptake time. If you took FDG and did the same thing and just did FDG twice, FDG would beat itself, hands down, with its difference in technique. It's a meaningless comparison. And so to me, what this really shows is that scanner and acquisition protocol is way more important than the radiotracer used. So the nice thing about nuclear medicine now, there's lots of innovation, right? Both in radiopharmaceuticals, radioligand therapies, but also in technology, right? In PET CTs, we have digital PET scanners, big field of view, Z-axis field of view scanners, and that is actually way more important than the difference in the actual radiopharmaceutical. And so to me, that's a take-home point here, is technique is way more important than PSMA-11 versus DCF-PYL. And I think it's really important to keep in mind when someone creates evidence that supports the use of PSMA PET with PSMA-11, it should be perfectly applicable to DCF-PYL and vice versa, right? So if you run a randomized trial showing that SBRT when using DCF-PYL shows benefit clinically, that is completely applicable to patients who are imaged with PSMA-11. Okay, the comparisons that do matter are comparisons like this. Actually, the one that really mattered to me was St. Vincent's back in the day when they did a fluorocholine versus PSMA-11 PET, really convinced me to move forward with this. But this was done by Jeremy Calais. You guys don't use fluciclovine in Australia, but in the United States, we used this drug for about 4 years before PSMA PET was FDA approved, and this showed a benefit of PSMA PET versus fluciclovine. This difference, this is real. There's a definite difference in detection sensitivity with PSMA-11 PET versus fluciclovine, and this is actually the type of comparison that matters clinically, as compared to minimal differences between PSMA-11 and DCF-PYL. Obviously, the increase in interreader variability or agreement is way more important as well. I just threw this slide in here. So RHPSMA 7.3 just read out at ASCO GU, showing fairly good sensitivity stratified by PSA, just to realize that this data is starting to come out on new compounds being RHPSMA 7.3. This will be probably the next FDA-approved agent in the United States. Probably about a year to a year and a half now, we'll start be using RHPSMA 7.3. There are comparisons of PSMA 1007 to PSMA 11. This is not in the same patients, but the interesting thing here is the orange. These are the lesions attributed to a benign etiology. You see a lot more ganglia uptake, bone lesions. Again, we don't use PSMA 1007, so I'm again relying on the literature. Here's an example of a patient image with PSMA 1007 from that manuscript, showing cervical ganglia, reactive nodes, a fracture in the bone, etc. So if you're using PSMA 1007, you do need to be aware of that in terms of interpretation, because there'll be a higher rate of those benign findings. There are comparisons of PSMA 1007 to DCF-PYL, and I think to me the important part here is that, and it's actually interesting, if you look in the right here, the lesions, white is DCF-PYL, gray is PSMA 1007, the uptake in the lesions are very similar, which is sort of interesting. The biodistribution is very different, right? So there's much higher uptake in the liver with 1007, kidneys, bladder with DCF-PYL, but the lesional uptake is actually very close. So even though the biodistribution is different, the uptake in the tumors doesn't seem to be that different. I'm going to highlight this other agent, phosphoramidate, CTT 1057. I highlight this because it came out of my institution, UCSF, and it actually just started also in phase 3 trials in the United States. This got licensed by Novartis. And this is the only agent that does not contain that urea backbone. It has a phosphoramidate backbone. And so it's a slightly different agent, but again, appears to have very similar uptake in tumors, although you can see there's a little more blood pool activity, so a little bit different biodistribution, similar to the other agents that we're talking about. Okay, so in the US though, none of this matters. Okay, the only thing that's going to matter is reimbursement, and we have some very odd rules in the United States, right? And the first 3 years you have a drug approved by the FDA, it'll get paid by Medicare, and over 70% of prostate cancer patients in the United States are insured by Medicare, and so if you get paid by Medicare, you're going to use that agent. So the point that DCF-PYL 3 years later goes off pass-through and is not reimbursed, everyone in the United States in 3 minutes will convert to whatever the next approved agent is. So there will be the cyclical moving through each agent solely driven by reimbursement purposes, having nothing to do with anything other than money, which is sort of sad, but just to say the frank truth about my country. Okay, the last thing I want to highlight is Pluvicto, and obviously PSMA 617 lutetium labeled was FDA approved last week, and in the package insert they said select patients for treatment using Locomets, which is the Novartis term for PSMA-11, or an approved PSMA-11 imaging agent, which would include Illuccix, which is the Telix kit, and then also the UCSF, UCLA NDA. Now, do you have to use gallium PSMA-11 to select patients for targeted radioligand therapy? No, obviously not. You should not be doing this. And to me, it's only the agents where you have hepatobiliary clearance that could become an issue, because in that setting, right, when you have hepatobiliary clearance and we're looking compared to the liver, right, because we don't follow Peter Mac guidelines, right? We are doing, is it greater than liver uptake? We're sort of stuck and handcuffed to the VISION trial. Then if you have hepatobiliary clearance, we got a problem. So that's the one space where that would be an issue. Now, when you look at DCF-PYL versus PSMA-11, this actually came out of Peter Mac, you can see that the liver uptake, that's sort of the fourth set of bars in, is nearly identical. Right? So with DCF-PYL and PSMA-11, you have very similar biodistributions, and your patient selection will be very closely matched. So I find them, and I think moving forward in the United States, people will use them interchangeably. When you come to PSMA-1007 and DCF-PYL, this is the study I showed earlier on the right, the uptake in the tumors is the same, but you can see the liver, it's a little, I didn't put a circle, maybe I put a circle, or there's a little circle around it. You can see the liver uptake is about twice higher with PSMA-1007, so you'll select patients differently. Now, if you're going to use the Australian approach, where you have a SUV of 20 or greater, 10 or greater, and you're not using comparison to liver, then PSMA-1007 probably would work as well. But in the United States, it probably is going to become an issue. So, in summary, one, in terms of ability to detect metastatic disease, I think PSMA PET agents should be considered equivalent, and we shouldn't be worrying ourselves with running trials comparing these. Two, there are differences in these agents, and particularly with 1007, there's more benign uptake in bone and ganglion uptake. And then third, for selecting patients for radioligand therapy, PSMA-11 and DCF-PYL should be considered equivalent. I think particularly from the American perspective, 1007, the jury's out yet, but that's going to be a couple more years before that becomes FDA approved in the US, so it won't be an issue for us. So thank you very much, and we will move on.